Well, good evening, everybody. Welcome to the Spina Bifida Association's Spina Bifida Occulta information session. I'm Brad Dicianno. I'm the Associate Medical Director for the Spina Bifida Association, and I'm also the Director of the Adult Spina Bifida Clinic at the University of Pittsburgh School of Medicine. And I have two experts today who are very knowledgeable about Spina Bifida Occulta that I want to introduce to you today. And we're going to hopefully answer a lot of questions and clear up a lot of confusion about Spina Bifida Occulta. First, I'd like to introduce Dr. Robin Bowman. She is Associate Professor of Pediatric Neurological Surgery at Northwestern University Feinberg School of Medicine. She's also the director of the Multidisciplinary Spina Bifida Center there and co-director of fetal neurosurgery at the Chicago Institute for Fetal Health. She's medical director for Camp Independence, member of Lurie Children's Surgical Foundation, and she also happens to be the new incoming chair of our Spina Bifida Association Professional Advisory Council. We also have Dr. Christopher Standaert. He is Associate Professor and Vice Chair for Outpatient Services at the Department of Physical Medicine and Rehabilitation at the University of Pittsburgh School of Medicine. And he's also Director of the Value-Based Fellowship in Spine and Musculoskeletal Medicine. So welcome, Dr. Bowman and Dr. Standaert. I'll start with you, Dr. Bowman. Can you tell us just a little bit about your experience in seeing patients with Spina Bifida Occulta?
Sure. So I take care of, I'm the director for our Spina Bifida Center. And so the children that I take care of that have any form of Spina Bifida or Spina Bifida Occulta have an associated congenital abnormality of their spinal cord, which is known as a tethered cord. So, early in development, when our spinal cord is forming, it's all the way down to our tailbone. It pulls up in the canal so that for a majority of us, the bottom of our spinal cord is right there under our rib cage. But there are times when it is held down, usually by fatty tissue. The most severe form of Spina Bifida is where the spinal cord itself is out on the surface and is attached. And so those are all different forms of tethered cord or spinal dysraphism that occur very early in mom's pregnancy, around week 3 of the pregnancy, actually.
All right, thank you. And Dr. Standaert, can you tell us a little bit about your experience in treating Spina Bifida Occulta, and tell us what spine and musculoskeletal medicine is?
So I'm a rehab physician, rehabilitation medicine. And so I have been treating non-operative spine and musculoskeletal problems for about 25 years in practice. And spine medicine really is sort of understanding the whole scope of pathology of the spine. And I would pretty much do everything sort of non-surgical with the spine and with somebody with a spine problem. So the most common things we see are back pain of various forms. Within that are lots of structural things that may or may not be associated with it. We see young spines and aging spines and all sorts of things. And so I've taken care of people with back pain and spine disorders and other joint disorders my whole career. That's really what I do. And I direct their rehabilitation, how they manage and live and function with whatever's going on with their spine, be it developmental or trauma or aging or what it might be. So in the course of that, I obviously look at lots of pictures of spines, lots of x-rays and MRIs and CAT scans. And that's where we see Spina Bifida Occulta. That's what the occulta word means, right? Occulta means sort of occult, meaning it's sort of there but not seen or terribly suspected. And so we find it a lot when we image people. That's different than sort of Spina Bifida per se and tethered cords like Dr. Bowman was just describing. Those aren't the patients I treat, but those aren't. Spina Bifida Occulta by itself is a different thing. It's a radiographic finding. So I see it a lot in the course of x-raying people with back pain, but I see lots of other things like degenerative discs and arthritic joints and other sorts of things that we commonly find.
When you do see it on an x-ray or on other types of imaging, how often do we see that? How common is it actually?
So it's more common in kids than adults because we grow, like Dr. Bowman was saying, our spines, our spine is growing as we grow. It's not fully formed when we are 2, right? It's still growing. So when you look at like series of films of young children who were 7 or 10, you'll find almost half of them may have a spina bifida occulta. But as they grow and get older, boys mature, they hit ultimate sort of adult bone density at 25, girls about 21. It takes a while, right? We grow. Most of those close over. If you look at series of pictures of adults, about 10% of people have a spina bifida occulta. It gets tied in a bit with numbering how many vertebrae we have. Like if you look at the textbooks, they say we're supposed to have 5 lumbar vertebrae. Vertebra are the bones in the spine. A lumbar vertebra is in your low back and it doesn't have a rib, right? The bones above them in the rib are in what's called the thoracic spine. We're supposed to have 12 of those. But only about 85% of people actually have 5 lumbar vertebrae. About 15% of people don't. And this is sort of normal, and this has been this way for a very long time when you look at sort of historical skeletons. It's just the way humans are. We don't all look like textbooks, and then we get older.
So it sounds like, as far as adults, almost 1 in 10 adults in the whole population can have this. So
yeah,
very common.
It's very common. Yeah.
And so just to reiterate, because I think people get a little confused over some of the terminology, even a lot of medical professionals get confused. Dr. Bowman, again, can you just explain the difference between occult spinal dysraphism and spina bifida occulta? The names are kind of similar, but what's the difference between those two?
Sure. When I think of spina bifida occulta, that has to do with the bones. And I think of, you have the big vertebral body, and then you have kind of the arms that come around, the pedicles and the lamina that come around to the spinous process. So that and that's what you feel when you feel your back. You're feeling those hands that have come together with the spinal cord in the center if you're in the upper part of the spine. And as we talked about, as you come lower, the spinal cord's not there. And it varies. Again, it can be up to 50% of kids or 10% of adults. But when you get lower in the spine, especially into the sacrum, when I see the kids, the bones, the arms didn't come all the way together. So the arms are open a little bit instead of being together in the spine. And that is spina bifida occulta. It's just that the bones at that stage in development hasn't come all the way together into the hands. So that's the bones not completely closing. Spinal dysraphism is where you, or spina bifida occulta associated with spina dysraphism is where you have an associated abnormality of the spinal cord. So what I always say to my families is a majority, if not all, children that I take care of that have spinal dysraphism or a tethered cord have spina bifida occulta. But there's many, 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 many millions more people that have spina bifida occulta that do not have spinal dysraphism or a tethered cord. So the spina bifida occulta, where it's just the bones didn't come together, is very common.
Thanks. And so I'll touch on that a little bit. So Dr. Standaert, if you do have spina bifida occulta just on X-ray, but you're asymptomatic, you have no symptoms. Let's say you're not having any back pain or not having any other symptoms, but somebody sees it on an X-ray or other type of imaging. Does anything need to be done about that?
No, we don't do anything about that. And frankly, even if people have just low back pain, not pain into their legs, not numbness or tingling or weakness or bladder difficulty or some other neurologic problem, if they just have back pain, we don't necessarily connect it to the spina bifida occulta because it's so common, and the vast majority of people who have it don't have ongoing back pain on an everyday basis, right? And so we don't think of it as that. And when I think of these things, when you look at how we grow, if you go to like an embryo, a very young sort of embryo, our spine starts as little things called somites, little clusters of cells. And then at every level, there'll be a little somite, and they grow around and they grow back in a little circle and do exactly what Dr. Bowman said. They grow backwards and they close over the arch in the back of our spine. And they sort of start closing at the top and they go down to the bottom. It's kind of like when you do a zipper, like if it doesn't quite finish, that's where it doesn't quite finish. And so these issues of it doesn't quite close all the way, which causes a spina bifida occulta, but everything else developed totally normally. the nerves develop normally, the spinal cord developed normally, the dura, the lining around our spinal fluid developed normally. Just the bone didn't quite finish. That's the spina bifida occulta that we see just on X-ray. And so by itself, with no other symptoms, no, you wouldn't do anything. If I saw it on a CAT scan of an abdomen, I wouldn't do anything. If somebody has back pain, I treat them for their back pain as I would other people with back pain through physical therapy and activity, and look at various other ways to help them.
Okay, and on the other hand, we may have people who have spina bifida occulta on imaging, and they are symptomatic. So, Dr. Bowman, what are the different forms of spina bifida occulta that can cause problems or symptoms?
Sure. So for the children I take care of, right, spina bifida occulta associated with a tethered cord could cause the neurologic symptoms that we were just talking about. So the spinal cord, I think of it as the bottom of the spinal cord doesn't want to be tugged on. And so anything where if the spinal cord comes down and opens up to the surface, the spina bifida occulta, it's hooked to the skin. So as that baby grows, that spinal cord is hooked at the bottom end to the skin, the spinal cord is tugged on. Or if there's fat that during the early stages of development in the womb, that fat gets in and hooks onto the bottom of the spinal cord. Again, as the baby grows, that puts a tug or a tension on the bottom of the cord, which can lead to neurologic symptoms. So if we would see like a lump of skin or a lump of fat under the skin, or if we'd see a dorsal appendage, a little skin tag, things like that would encourage me, if you saw that, to get some further imaging to make sure that the spinal cord looks good and developed normally.
And Dr. Standaert, if a person perhaps is having symptoms and we're concerned about some neurologic symptoms, are there any like red flag symptoms that might indicate that maybe the spinal cord is involved or something else is going on that we should investigate?
Yeah, so I mean, if you took adults with back pain or older adolescents with back pain, and then you said, oh, you know, if it's just back pain without any neurologic things, with normal skin, normal soft tissue coverage, like everything grew normally that you can see. Again, we don't really treat that differently than somebody else with back pain. When you start getting numb, tingly, weak, persisting, we talk about neurologic symptoms from nerves in your back, numb, tingly, weak, and the tethered cord really affects bladder function in particular, right? You start wondering if my bladder function is changing, it's not, that sort of thing. In general, we tend to pursue those more. Those are different problems. We start working about nerve compression. And, you know, most common causes in adults are going to be things like a disc or arthritic sort of changes that compress a nerve. Especially if somebody younger with getting neurologic things, we do tend to go look. As teenagers, that sort of thing, getting leg symptoms is pretty uncommon. We would be very inclined to sort of see them and evaluate them and get an MRI and look at the end of their cord, and are they tethered or do they have a disc or something hitting their nerves? Because that's not a common symptom in 17-year-olds. Back pain is pretty common, but not the leg stuff. And so the neurologic things tip us into a different category than back pain. I don't want to say just back pain, because back pain can be very disabling for people, so it's a significant problem. But we treat it differently. We don't get as surgical. Things are very different when you start treating leg pain, sciatica, numb, tingly, weak, bladder, bowel difficulties. As a whole different category of stuff for us medically.
And Dr. Bowman, if a person is having those types of red flag symptoms that might indicate that there is something wrong with the spinal cord, we talked a little bit about MRI. Is that what is typically done at that point to look at the spine?
Yes, it's the best way to get a good picture of that spinal cord, and make sure that there's nothing holding on, there's no fat there tugging on the bottom of that spinal cord that could be accounting for those neurologic symptoms. Of course, there's so many, right? So many reasons to have changes in our bladder or bowel function as we age, or leg symptoms. But if you have that associated spina bifida occulta Perhaps if you have something that we see over the spinal midline. Yes, the first thing we would think of is, and neurologic symptoms would be to get that spine MRI.
And what if the patient is a baby? What would we do then?
Yeah, we still, you can start with a spinal ultrasound. I know that there's many pediatricians who, you know, the beautiful thing about a little 2-month-old baby, right, is you can get, their bone isn't ossified. It's more cartilage than bone. And so you can see through that with the ultrasound. The tough thing is you don't always pick up everything. I still think probably the gold standard is that spine MRI. But you know, the downside to it is, right, you may have to be sedated to lay still. So, or many times, many of the MR suites today work with the families and do what they call a feed and swaddle. So, you know, get their tummy full and get them nice and warm and cozy and zip them in there for a quick picture if they need one. So yes, it can be. There's no radiation involved with MRI. So even, you know, our pregnant mothers are going through MRs today with no worries. So yes, it can be done. An MR can be done at any age.
Oh, thanks. And Dr. Standaert, so one possibility is that, let's say a patient presents with these symptoms and we do get the MRI and we look at the spinal cord and the spinal cord is normal, but maybe there's some problems with the bones, discs, or soft tissue, but not the spinal cord. If that's the case, what is typically done at that point?
Well, it depends sort of what the issue is. So in this concept of a tethered cord, what we see is what Dr. Bowman said, that when we're very young, embryo, our spinal cord is the same length as our spine. As we grow, though, the spinal cord stops growing and our spine does. So it sort of moves, it looks like it moves up. Basically, it stays attached to the brain and you grow and the bone grows, but the spinal cord doesn't. So it moves up in our spine. And normally it ends right around the bottom of your rib cage. And so we can see that a normal lumbar MRI scan, low back MRI, goes up high enough, and then the radiologists almost always routinely go look for where the spinal cord ends. They look specifically for that issue. And so when we see it go too low, down to about L3 or so, we start wondering, could it be tethered in an adult, right? It's uncommon in adults. We do see that once in a while, and that's sort of, we have to then sort of go through that. For other things, you know, you get into discs are different than bone spurry kind of things. An acute disc injury, most of them actually get better. We operate on maybe 10 or 15% of disc herniations. 85–90% get better with time and rehab and some supportive medications and a bit of patience. We don't operate on the vast majority of disc herniations. When you start getting significant arthritic changes and spinal stenosis and compressing nerves, more typical in an older population, that's a different story. What do you do with that? You know, can we rehab our way through it? You know, sometimes we try various medications. Sometimes we go to surgery for spinal stenosis, narrowing around the spine. But we try to operate in a minority of our patients, so we try to manage them without that for the most part. We help them through it and understand what it is. And even spinal stenosis, if you track people over time, about an equal number will sort of spontaneously get better or spontaneously get worse. So we don't jump in and like cut them open right away. We give them some time and work with them a bit typically, unless they're having significant neurologic concerns. We're worried they're going to get worse if we don't decompress their nerves, take the pressure off them.
So a lot of people say that they have a difficult time finding a specialist or really understanding what kind of specialist should see them for what kinds of problems. So what's the role of a physiatrist, like a rehab doctor, or a spine surgeon or a neurologist in the situation where there's no tethered cord, and you're really having a problem more like with spinal stenosis or a disc problem? It's not a problem with the spinal cord itself in terms of tethering.
That can definitely be a little tricky in terms of what you can find. Most primary care doctors can see acute low back pain and fairly straightforward things. If you're sort of not doing well with therapy or things are going number tingly, you're getting past what most of them would do. So a physiatrist, someone like myself who's a rehab specialist who does spine care, Certainly, I see a whole scope of spine problems, and I would see people with numb, tingly, back pain, weak, all sorts of stuff. There aren't as many of us as there are neurosurgical or orthopedic surgeons who do spine care, and most orthopedic and neurosurgical providers still see a lot of non-operative care. They don't operate on most of their patients, right? Most of their day is spent helping people manage it non-operatively. So usually after your primary care, they would sort of know hopefully they know people in the area to help you know who you could see who does this. Some physiatrists are purely do procedures. They wouldn't help you manage this. They're not the ones to see, but the ones who see people on an outpatient basis for spine and joint problems would be that's where you would start a lot of the times if there isn't someone like me around, because there aren't as many of us. A lot of community-based orthopedic surgeons and neurosurgeons will see, spine disorders of various sorts, and they'll sort through is it surgical or not, because they're the ones who do that in that community.
Great, thank you. And so then on the other hand, let's say we do get the lumbar MRI or a spinal ultrasound, and we do see an abnormality of the spinal cord, like the end of the spinal cord is low, or we see some tethering or some fatty tissue in there where it shouldn't be. Dr. Bowman, who should evaluate that patient in that situation, and what's typically done?
Sure. Well, for us, we approach it as a team. I think it's always good to be as objective as possible in that evaluation, so that and again, I take care of just babies and children, but they come in to see me initially as the neurosurgeon, and then I usually get my colleagues involved in orthopedics and in pediatric urology, because a tethered spinal cord, the bottom of our spinal cord, is what gives the nervous supply, as we've talked about, to our legs, bowel, bladder, sexual functioning. And so the leg strength, to make sure that the tone is good, that there's no deformity of those feet, I really rely upon my physical therapists and my orthopedic surgeons to get a good baseline evaluation, and have them and the rehab team to have them let me know if they see anything that's concerning to them, that this tethered, because many times people get confused that you may have a tethered cord on your imaging study, but you may have no symptoms of it. And so not every tethered cord requires surgical intervention. So that's why I say I want to be as objective as possible, so that I have a good baseline evaluation on that child that I can follow throughout childhood. And then we do some evaluations of their bladder, because those last nerve roots off the spinal cord, which can be affected by tethering, those sacrococcygeal nerve roots supply it supplies bowel, bladder, sexual functioning. So we kind of get at the function of those sacrococcygeal nerve roots by evaluating the bladder. And that's where the pediatric urologist does some studies on the bladder and helps us with how they think that bladder is functioning. So we really approach a child with a tethered cord as a team, and discuss kind of what is their baseline function. And if they're doing well, then my team kind of helps me set up, well, how frequently should we see this child and follow them? Because just because you don't have symptoms today doesn't mean you won't develop them in 6 months, 6 years, or 60 years. The tough thing, right, is we don't have any natural history study out there in the literature that I know of where we can tell a family when they have a family member that has a tethered cord. I have no way of predicting for them if throughout their lifetime they'll develop symptoms, or if they will, when they will. And so that's why I think it's so important to get a good baseline evaluation on them, and then make that decision as to whether or not you think surgery to release that tether, to release that fatty tissue away from the spinal cord, it would be a benefit to help improve the neurologic function and help, and then follow them long term, of course.
Some physicians use the term tethered cord syndrome. Can you kind of explain what's the difference between tethered cord syndrome and just a tethered cord?
We tend to throw around a lot of terms, don't we? It's confusing to me too. And I'm in pediatrics neurosurgery, and this is my this is my little corner of the world. I tend not to use the word tethered cord syndrome. I presume that for those that use the word, that they're more leaning toward a patient that has tethering that you see on the MRI, and they have some type of neurologic symptom associated with it. So again, tethering, as I always tell my families, it has nothing to do with, right, our hand strength. It has nothing to do with cognitively how well you're doing. It's the bottom end of the spinal cord. So if you're seeing changes in those legs, bowel, bladder, sexual functioning, that's part of the syndrome. But again, you can have evidence of tethering, and some people can go a lifetime and have no symptoms associated with it, which is really, I wish we understood that better, right? As to why do some people have more plasticity with their nervous system and others really don't. And that part of it, I just don't know.
Well, that's really helpful. I wanted to point out at this point that we've talked a lot about kind of decision making and how to think about symptoms and what specialists to see. And I wanted to point out that at Spina Bifida Association, we developed a document to kind of help as an information sheet. So we'll provide that link to everybody, so that's accessible, and you can review some of the information that we just talked about. And I want to also kind of turn to some of the questions that have come up with the SBO community. There's a few things that people ask commonly, and I wanted to talk about some of those. One thing that somebody asked was that, explain again, some people can be born with a tethered cord, but Dr. Bowman, can a tethered cord just develop later in life? Can it just appear in an adult who never had it before?
Yeah, so remember that tethering of the spinal cord, what you see on the picture, that happens at week 3 of mom's pregnancy, right? So that's not something that you don't grow that fat, or it doesn't grow into your spine and attach to your spinal cord when you're 10. That's something that happens at week 3 of your pregnancy. But you can have evidence of tethering on your imaging from week 3 of mom's pregnancy that doesn't, and you never develop symptoms of it for a lifetime, or you can develop symptoms of it when you're 10 years old or when you're 50. So it's not that fatty string or that fatty tissue just developed then. It's that perhaps it wasn't until that point in your life that you developed the symptoms, which some people at that point say, then you have the tethered cord syndrome, right? But the actual tethering, the tethering lesion, if you will, has been there your whole life.
Whole life. That's very helpful to know. And some people who live with tethered cord want to know, is there anything they should avoid doing? Sometimes they're afraid that certain movements, they'll use terms like, will my spinal cord snap? Will the tethering snap? Will something tear? Do we really limit what people are allowed to do if they have a tethered cord? This question's either for either of you.
We want everyone to be as active, right, as possible. I think we've talked about it before. If you're doing something and it makes you really uncomfortable, you're doing extreme flexion, and it gives you back pain or leg pain, then I'd go a little easier on yourself, right? But that sometimes can be hard, I think. And Chris, maybe you can address this. Sometimes I've had teenagers that get a little confused by maybe they haven't been active for a few years, and then when they start to get active again, they get some leg cramps, or because they're tight, their muscles are tight. Kind of the difference between that or just the usual soreness, right? I'm terrible at exercising myself, and when I get back at it, I pay for it for days on end. And how do you, when somebody says, you shouldn't push yourself to where things are really too extreme, How do you judge that with your patients?
Well, there are a couple of questions in there. I think for the tethered cord thing, we find tethered cords for one of two reasons in adults. They have back and leg pain, and we find it sort of by chance that we MRI'd them for something else, say their last lumbar disc in their spine, which is where the problems are more often. And we just happen to see that the spinal cord sits relatively low in the spine. We go, huh, you have by MRI standards a tethered cord, but you have no symptoms of this, and you've never had any symptoms of this, and your leg pain is from this disc herniation sitting on your nerve at L5.
Yeah.
And then we have people where really they come in and they give us a few neurologic symptoms and some bladder symptoms, and we go, I wonder, and they have a scoliosis or some other thing, we go, I wonder if they have a tethered cord.
Yeah.
And then they have a tethered cord. So those people, I'm the rehab person. If I had somebody where I really thought the tethered cord was causing problems, I'd have them talk to a neurosurgeon. And then we would go through pros and cons of this, right? There's no surgery that has no risk, and there's no surgery that's 100% perfect.
Yeah.
So you go through this, and how bad are the symptoms, and what are you doing? And so in somebody who has a known symptomatic tethered cord, you would keep them within bounds of what sort of sets off their leg symptoms, right? You would think most things like swimming and biking and walking and things like that wouldn't bother them at all. It tends to be what Dr. Mo was saying, things where you really bend yourself and straighten out your legs, like thinking like really sort of bending down to touch your toes and really compressing yourself tightly, that sort of thing. Is that tends to sort of lengthen your spine. And if your cord doesn't lengthen with your spine, then that's when the symptoms occur. But the majority of people in whom we see these are probably not symptomatic from it. We just find it incidentally with their cord ends at L2 or L3, and we're like, huh, you're kind of low, right? But if we don't have any symptoms to it, we don't really particularly restrict them from anything. And I think in the low back pain world, fear of something bad happening to you from a problem with your back is a bigger problem than actually doing things for the most part. We don't want people afraid. We want them living and functioning and doing things. And really the normal routine of daily life and normal exercise approaches people do in a gym, ellipticals, treadmills, walking, bikes, hiking, these are not problems with what we're talking about. They're good for people. We don't want to restrict them from that. We want them doing those, because really, if you start thinking, I have back pain, I have a back problem, the best things you can do are to be healthy, right? We don't want people overweight. We don't want them underweight. We don't want them inactive. We don't want them inflexible. We want them strong and healthy and flexible and moving and active. And that's what back health is tied to health in general, right? So we don't want people smoking. We don't want them overweight. We don't want them inactive, because it's tied to health in general. We don't want them depressed or anxious. It all loops together. So we want people doing things. So we wouldn't really overly restrict people. And especially for something that was essentially not causing problems, we wouldn't want to then curtail somebody's activity.
I want to turn a little bit to some of the questions that are popping up in chat. And we talked about tethered cord and spina bifida occulta and how they're related, but this is an interesting question. If you have a tethered cord, do you automatically also have spina bifida occulta? And on the other hand, how many people with spina bifida occulta have tethered cord?
So the first one is no, you don't have to have spina bifida occulta to have a tethered cord. Very few people with spina bifida occulta as an adult have a tethered cord. It's a very small number. I don't know the number, is very small. Because spina bifida occulta is 10% of the population. Tethered cord is a fraction of that. So the overwhelming majority of people with spina bifida occulta as an adult do not have a tethered cord.
So if that's the case, we hear a lot from the community about how frustrated they are that they have pain or they have some of these symptoms, and they feel like providers don't believe them or don't think that their pain is real. So if the majority of people who have spina bifida occulta aren't having pain because of the occulta, can you again just kind of explain how their pain can be real and not be from the spina bifida occulta?
So back pain is really tricky. I mean, essentially everybody gets back pain at some points. Like when you listen to doctors say 80% of people, I can't imagine anybody hits 50 who has never had back pain, right? It seems almost impossible.
Mm-hmm.
About 10% of people really have significant pain that limits their function and occurs frequently on a daily basis or very often. And that's a different category. And it's very hard to sort out the cause of back pain. The real difficulty is that if we go looking at spines of 50-year-olds, they don't look like spines of 20-year-olds. They just don't, right? We get arthritic, we grow bone spurs, our discs change, our anatomy changes, the actual structure of our spine is different at 50. The discs are different. They have a different anatomic structure because it changes with age and time and exposure. And unfortunately, things we see on all sorts, we do lots of tests, and mostly we find out people are 50, because they don't really tend to line up with why they hurt. And we see this all the time. We see discs that don't look normal and joints that don't look normal, but we see lots of them in people who don't have any back pain. So it's very hard to look at a picture of an MRI and say, I know exactly why you hurt. Sometimes we get an acute fracture, sometimes an acute disc that looks like clearly a new injury tied to exactly what the patient's telling us with their nerve. Then we're a lot more confident we know what it is. When it is a spina bifida occulta has been there somebody's entire life, right? It basically was present when they were a child, like Dr. Bowman was saying, and this is one of the ones that didn't finish closing over. Those little arms did not grow together, but it has been there since they were born, right? And it just didn't quite finish growing over. So to, it's been there their whole life, right? And so it didn't just appear. And so in that case, what we do is we say, okay, we have to deal with why the back hurts in general, and back pain, again, is tied to these other issues of general health and function. So we look at how people use their back, how they move, but back pain can be driven by problems in the legs, like, they have a bad hip, they have something else, lack of exercise, lack of movement, lack of strength, lack of flexibility. All these things feed into back pain, and they get tied into other factors in life, where some people, they have too many other responsibilities and really can't take adequate care of themselves, right? They have multiple family members and aging family members and 2 jobs, and it's hard, right? And human beings in general, the sort of walking on 2 feet things is hard for our spines, right? We age. And so in general, we just try to help people be healthier around that, healthier around their spine and healthier in general. And that generally helps them feel better and function better. And that's largely how we treat low back pain. There are a lot of specifics to it depending on the circumstance, but that's largely what we're after. And Spina Bifida Occulta doesn't really change that. Again, just for back pain, absent these neurologic concerns we were talking about.
Mhm. And so we've talked a little bit about the different specialists that can be involved with different situations depending on what's going on with the spine or the pain. And a lot of the community expressed frustration that, we take they feel that physicians take symptoms more seriously in children and kind of brush them off with adults and just kind of blame everything on, quote unquote, aging. What is your thought around that? Do you think that we tend to focus more on children than adults, and how do we advise the community about, getting care if they're an adult and they're having trouble finding a provider?
I mean, I think it gets tricky because I think, most people will see their primary care provider, and the spine is really complicated, right? The anatomy is complicated. The number of things that happen, even a normal MRI report can be 2 pages long, right? Filled with essentially language that is derived from Greek, right? Unless you read those all the time, you really don't understand what they say. And to interpret an MRI report or an X-ray report, you have to be used to sort of what you would expect for that person, right? And if you look at, they change by age. 60-year-olds, again, we don't see the same frequency. I mean, the same number of findings in 60 and 20-year-olds as we see in 60-year-olds. We have a range for what we expect by a given age. Activity level matters. So really active adolescents have different looking spines than inactive adolescents, and high impact athletes have different spines than swimmers, right? Gymnast spines don't look like swimmer spines. It's sort of interesting, right? But to really understand this, you have to have that in your head. So as you're the physician or clinician looking at it, you have to know the background of what might I expect for this person's life and what might they have. And then how do I find things that are out of line with that are problematic? How do I find a broken thing? How do I find a disc herniation that shouldn't be there? And it's actually hard to do. And when things get complicated, you have to get out of the primary care doctor because they have the same problem. They don't have extensive training in what Dr. Bowman does. They just don't, right? And they don't really have extensive training necessarily what I do. That's why we do this, because there are people like us. And so I think doctors tend to be a little quick with this sometimes and say, oh, your MRI shows you have a bulging disc. That must be why you hurt. That's really not a fair thing to say to a patient because the doctor doesn't actually know that's why they hurt. Not that they couldn't hurt from their disc, they might, but it's very hard to know by looking at it. And I think our system makes it complicated. The language is complicated, the studies are complicated, the amount of sort of information you have to really interpret it well are complicated. And I think the information that gets through to patients often is not totally accurate, unfortunately. And they make associations that may not necessarily be true. And that doesn't necessarily minimize the fact that they have pain, right? Pain's pain, right? But being able to say that pain is from this thing is sort of different. So I think our system makes it very challenging to sort of navigate this. And if anything, MRI has sort of confused it more because we see so much, right? We just see so many things in an MRI. And, you know, we all get trained in textbooks and people just don't look like textbooks. They just don't, right? And I have these little pictures in my office of like patients come in, they have these beautiful drawings of spines on the wall and what they should look like. None of my patients look like that. Right? So we have to sort of manage that. And that's managing expectation and aging and injury. And I don't think you can say somebody's pain is just from aging, because that you don't want to, that hurts, right? A bad hip can be just from aging, but sometimes you need a new hip because you can't walk because your hip is so bad, right?
Sometimes it's still treatable, perhaps.
Yeah, very much so. Yeah, we can't treat the aging part, but we can treat the effects of aging. Yeah, we can optimize that.
And go ahead,
Chris,
Doctor.
can I just ask you a question? Would you say that, and for patients that you treat with back pain, that what works to lessen their burden of pain is it's very individualized, that that you have the same different things that you can try and help them with, but it's not one size fits all, I guess is what I'm asking.
It's definitely not one size fits all. People have different problems. They have different anatomic things that affect them. They have different demands in their life. They have different experiences with activity and exercise and movement. Some people are very flexible. Some people are very inflexible. Some people are very thin. Some people are not very thin. You know, all these variations sort of matter. And then, you know, other issues of stress and other illness, and people with, you know, some people have immunosuppression, which changes things. Like they have other things. Some people have inflammatory disorders. Some people have, you know, GI disorders and have, you know, issues with sort of absorption of various minerals and things that make it difficult. So there's a whole, it really is individualized. And the real idea of treating the backs, you know, what I tell all my patients, it's really not about the back pain events, it's about your life, right? We want you to get back to your life and be functional and be doing enjoyable things that are meaningful for you and staying healthy. And that does very much become an individual thing because everybody's life is somewhat different. I agree with you totally.
We have a question about Spina Bifida Occulta appearing on the thoracic part of the spine. How common is that? Is it usually lower down, or can it be up at the thoracic spine? And is it less common to be that high?
I've seen it just about everywhere. It's just much less common. It's that zipper thing. The zipper goes down, and most of the time, if the zipper doesn't close, it doesn't close at the bottom of the zipper. But I've seen them in the thoracic spine. I've seen them in the cervical spine. It's these, like, again, when we're an embryo, or if you look at a very early embryo, what you see is just a line of dots. There's not a vertebra is a big bone that grows a circle behind it, an arch. And there's a canal in the middle that runs down the back, and that's where your spinal cord goes. But that arch is what forms. That's what Dr. Bowman was describing early on, the fingers growing back. That arch is what forms. And if that arch, just the two sides grow back, but they don't quite touch and grow together, that's the Spina Bifida Occulta. And so it is much more common at the base of the spine. So when we talk about how many people have how many vertebrae at different levels, how many lumbar bones, how many vertebrae, how many lumbar bones do you have, how many thoracic bones do you have, how many ribs do you have? Not everybody has 12 ribs on each side. It's sort of curious. Some have 11, some have 13. It's kind of funny, you know. It varies, but most commonly these are lower down. These are the bottom of the spine, but they can happen anywhere. I've seen them in the cervical and thoracic spine, certainly, just uncommon, very, very uncommonly.
And we had another question about a syrinx or syringomyelia, the fluid collection in the spine. And people want to know, could that be related at all to having spina bifida occulta?
The times that I've seen fluid in the spinal cord and seen spina bifida occulta, it's in someone that has a tethered spinal cord. Well, that's not true, but I would say the most common, right, is with tethering of the spinal cord, you can see fluid accumulate at times inside the cord, which we, again, like everything in medicine, we have so many crazy words that mean the same thing, right? We can call it hydromyelia, so water in the cord. We can call it syrinx or syringomyelia. Some people slur it all together and call it syringohydromyelia, or they reverse it and hydrosyringomyelia. And I think it's very confusing. I get confused. There are other times, and I'm sure that you all have seen the same thing, right? Again, there's many of us out there that have some spina bifida occulta down in our sacral region. We also at times, and again, I treat just children into their teen years, but where we'll see just little teeny segments of a little bit of fluid in the spinal cord with nothing associated with it, with no tethering, with no Chiari or brain abnormalities. They've not had an injury to their cord. They don't have a spinal cord tumor. I think of those when we see just little segments that just sit there. And there's some studies in our literature that show that those really never change. And I think of those as more developmental in nature, meaning, early in development, our spinal cord actually has a tube of fluid on the inside of it, and then it seals down. And for some of us, that little tube called the central canal doesn't seal down completely, and we just hold a little bit of fluid there. And it never, there's plenty of studies that have shown those little segments don't always change. And so there are times when you could see that also. So I hope that answers your question, Brad.
Yeah, I think that's what they were getting at. If not, please go ahead and post a clarification on your question. Another question, we talked a little bit about, not really needing to necessarily limit activities, but people sometimes have some questions about, like, if they do have an existing tethered cord, are there certain things that they might experience that could cause them to have symptoms? So, and some things are like car accidents or giving childbirth, like vaginal delivery, where there could be some stretching of the cord. Are those situations where it's possible that people could have symptoms from a tethered cord?
I don't treat many adults, so I wouldn't say that many of my patients are having children. I would think it would be possible, but not very probable. I don't know if you have much experience with people developing symptoms after such.
So I have not seen it with childbirth. I'll get that in 1 second. So if you have a trauma that so we keep using this phrase tethered cord. If you look at your nervous system, you have your brain sitting in your skull. Your spinal cord is essentially part of it, attached to your brain, right? It turns into your brainstem, which is the upper part, and then your spinal cord comes down. It's one giant unit, right? So the spinal cord is made up of cells that run down your legs, but lots of nerves that are coming down from your brain, or that's really what your spinal cord is made of. That's what it is, right? These sort of axons and wires coming down from the cells in your brain, right? It's one unit. And so normally that cord goes all the way down, and there's a little fibrous connection that ties that cord to the base of your spine in everybody, right? In a tethered cord, that little connection is too short, or it's fatty, or it's deformed in some other way, or it doesn't develop right, and so the spinal cord gets stuck. It doesn't move up as we grow, right? So if you think about somebody who has a pre-existing tethered cord, say their cord goes all the way down to the L3 vertebra, which is the middle of their lumbar spine, which is too low, which is where we start to define a tethered cord by MRI. The problem is that if they rapidly sort of extend their spine gets longer really rapidly. They bend at the waist and their spine goes whoop and like really lengthens quickly. in a high velocity sort of thing, you could yank on that theoretically. So I could see somebody getting snapped forward or compressed in a way with a tethered cord where they get elongated just subtly. They don't have to get elongated by 2 inches, right? Just even a little bit if that cord's really tight. I could see that being a problem, or like a bad fall, like if you fell on your backside with your legs out and you compress and you sort of jackknife yourself a bit. So I could see that. I don't know that I have seen it, but I could imagine that if somebody had a tethered cord, that would not be a good thing for them necessarily. Childbirth gets if you have a tethered cord and you go to childbirth, this gets a little tricky because you think about like they do epidural anesthesia for a lot of women who go through childbirth, right? They have to put a needle in your spine to give you anesthetic. If your spinal cord goes all the way to L3, they don't want to put a needle right there. That's usually where they would go. Right. So if you have even known tethered cord and known anomaly, my patients who I know have something unusual about their lumbar spine, we have conversations about how they get through anesthesia. The anesthesiology people really ought to be looking at their cord and their imaging before they do anything. And then you have conversations about with the OB about, you know, vaginal delivery or not. Right. Do you do that? But that gets to be, so Dr. Bowman was talking before about a team thing. Right. That gets to be a conversation of between, you know, your spine person, be it me or your neurosurgeon and your OB and the anesthesiologist. What's the best, you know, pregnancy? I've always been taught that the goal of pregnancy at the end from a doctor's standpoint is a healthy mom and healthy baby, right? That's what you want. And you pretty much do whatever you have to do to get to that point if things go awry, right? So you want healthy mom and healthy baby. And so you, in my patients who I know have congenital issues or significant structural problems in their spine or multiple disc issues or a couple of surgeries by their mid-20s, we have these conversations that it is no longer routine anesthesia, it's no longer routine childbirth, right? And then we have to, then it depends a bit on the mom and their preferences and the OB's preferences and the size of the kid and like all these things, but that becomes a team-based discussion to get to healthy mom and healthy baby, because that's what you want, right? And the team in that case is your spine person. You'll usually be someone like me or a neurosurgeon typically for this sort of thing, or maybe an orthopedic spine surgeon, and your OB and your anesthesiologist, because you really have to think about that a bit. Yeah.
And speaking of babies, we have a question. This might be a tough question, but
It's for Dr. Bowman.
Spina Bifida Occulta and or tethered cord related to folic acid deficiency, and so can it be hereditary? Can it be prevented?
Yeah, that is a tough one, right? I tell my families, spine. So we know open spina bifida, right? If you've had a baby with open spina bifida, you're at an increased risk for having a subsequent pregnancy with open spina bifida. And we know from population studies that we can block, right, or prevent that spina bifida from occurring again in 80-85% of women if we give them the high doses of folic acid. So if you've had a prior pregnancy with we say neural tube defect, right, because it can happen anywhere along the brain and spinal cord where it doesn't form normally, then your obstetrician is going to recommend that you're on 4 milligrams of folic acid before conception. Because remember that the spinal cord closes and all of this happens at week 3 of your pregnancy before you even know that you're pregnant. So usually they recommend you start that 4 milligrams of folic acid a month or so before conception. And that's for open spina bifida, where the spinal cord comes down and is open at the surface. But all of the studies, and correct me if you guys know anything differently, but all of the studies, those population studies that showed the positive impact of folic acid is in open spina bifida. It's not in the closed form of spina bifida, meaning the tethered, where we see tethered cords, the lipomyelomeniingocele, where the fat comes in and joins, the fatty phylums, where that little string has fat in it, or the cord didn't ascend up where it should. We, to my knowledge, have no proof that runs in families. As I tell moms who quiz me about it, I don't know that it hurts you to take the extra folic acid, but we have no proof that that your subsequent children are at risk for it, or that we can prevent it by you taking that extra folic acid.
And what about, we talked about Chiari malformations, specifically type 2 Chiari malformations, which we see a lot in myelomeningocele, an open type of spina bifida. One person wants to know, do people with spina bifida occulta get type 2 Chiari malformations?
Oh, fantastic question. Very, very good. Lots of good reading going on amongst our team here. So I think of, first let me say Chiari, for all of those that haven't Googled it. Chiari was a radiologist who described findings in the back part of our brain. And there's Chiari 1, Chiari 2, Chiari 3, Chiari 4. They're different diseases. So it's not a progression of disease, it's different diseases. Chiari 2 is what is associated with open spina bifida. So that baby that is forming in the womb from week 3 of your pregnancy on, where the spinal cord is open to the surface, and that spinal cord is leaking spinal fluid. And I think we can all envision that a baby from week 3 on, where the spinal cord is open and leaking spinal fluid, that is not a typical situation for the brain and spinal cord to be developing, with the bottom end of the spinal cord leaking spinal fluid. And so that kind of sets the nervous system up for having, as I say, unique wiring through the nervous system. And you can see changes throughout the brain. We often talk about the hindbrain or the back part of the brain, the things that we can see on an MRI, and it's called the Chiari 2 malformation. And yes, there are findings in the back part of the brain, but it's really the abnormalities that you can see throughout the nervous system that's related to the bottom end of the spinal cord being open and leaking spinal fluid from very early in mother's pregnancy. So this is not something that's associated with just the bones not coming together into the hands. It's something that's associated with that actual spinal cord being out there on the surface and leaking spinal fluid. So I hope I explained that so that that makes sense. But wow, really in-depth question. Thank you.
We have a lot of great questions. We're getting close to the end of the session. There are at least 30 more questions, so we're obviously not going to get to the rest. We'll try to answer some of the questions offline, but I wanted to thank you both for being with us today. Is there anything that we missed that you feel is important to fill in? Any final comments?
I think there's been some great questions today. The main thing is this is such a multidisciplinary approach, right, to spina bifida occulta and pain, because both are so common. And I know, Chris, you treat a lot of patients like that, that sometimes we think that one causes the other, when really it's that you can have both and one may not cause the other. And pain is very real, but there's so many reasons to have it. And there's so many people in the world that has spina bifida occulta and no symptoms related to it.
Yeah, and I think, people just need some guidance on how to get that proper workup and management if they are having pain. The pain may be real. It may not be related to the spina bifida occulta. It may be, but it's important to get the right workup because that will really guide what type of treatment people should get. And as a reminder, we did post a link to an information sheet where we provided some of this information to help you navigate these kinds of questions. A lot of people ask, if I'm someone in the community, how could I get more information, or how can I get involved in advocacy? Remember, these sessions are all made possible by the Spina Bifida Association. So if you are out there in the community, please go to the spinabifidassociation.org website and see how you can get involved in educational events, advocacy, fundraising, other opportunities to really support SBA so that we can develop more sessions like this for the SBO and SB community. And I also wanted to point out that we do have a National Resource Center, and we will post information in the chat about how to access the National Resource Center. If you have questions or need help finding a provider, our National Resource Center can be helpful. And we also have clinics posted on the Spina Bifida Association website. So if you go to the top under the tab clinics, you'll be able to look for clinics that might be available in your state where you can get care. We do have links there to pediatric and adult clinics. But of course, if you're having trouble finding care as an adult, reach out to our National Resource Center and we'll see how we can help you. So thanks again for joining us tonight. I hope folks enjoyed the session and learned a lot. Reach out to us if you have more questions, and we'll be in touch soon. Thanks, everybody.